So, first of all, I would like to thank organizers for a kind invitation for 35 Great Wall International Congress of Cardiology and also as in Heart Society Congress. I will discuss today about concomitant atrial fibrillation ablation in mitral valve. Nothing to disclose with this presentation, but you'll. And I would like to start with long-term survival of patient undergoing valvular heart surgery with and without surgical AFib treatment. The red line shows us the survival rate without combined surgical treatment of mitral valve pathology and atrial fibrillation is highly significantly less to compare when you perform combined surgery. It means replacement or recovery of mitral valve. Also, you made the so-called Cox-Maze procedure. Damiano, Lee, and Iriben quite effectively show this. McCartney a couple of years ago published data for 80,000 Medicare beneficiaries with a different type of heart pathology. And if you will see the mitral valve replacement patient had 60% of atrial fibrillation. Only 38 of them underwent combined surgical ablation for mitral valve surgery and atrial fibrillation. Not too much, but in our country, we have only 10% of this combined case. What about clinical practice guidelines for today? Different was many times ago, but today, according STS, AATS database, ACC, ACTTS 2024 guidelines, combined procedure for atrial fibrillation in mitral valve surgery, class 1 indication, level of evidence 1A, very high. It means for mitral valve surgery, if patient has paroxysmal or persistent atrial fibrillation, we should perform combined procedure, which reduce additional risk of operative mortality and major morbidity. Issue to discuss today is surgical treatment of persistent atrial fibrillation concomitant to mitral valve surgery. And after that, I will show our personal results. Gold standard is the cut and seal Maze 3 procedure, which was introduced by James Cox 30 years ago with excellent result in many for long-term follow-up. But unfortunately, sometimes in older patients with fragile left atrium, it's difficult to do the cut and seal technology. Today, we replace cut and seal by bipolar radiofrequency ablation technique in cryoablation. So-called the Cox-Maze 4 surgical technique, which was introduced 20 years ago by Raif Damiano and his team, includes a line which replicate cut and seal by cryotechnology or radiofrequency ablation, by sternotomy or right minitoropectomy. Most important part of this biatrial approach, always for persistent atrial fibrillation, is electrical isolation of posterior wall of left atrium. This looks like here. It means this area should be electrically silent after this type of procedure. If it's done, you will have 66% sinus treatment after 5 years follow-up without antiarrhythmic dust. If it's not isolated, only 33%. Second part of the procedure is repair of mitral valve. We're using Carpentier principle for leaflet correction, valvular apparatus correction, and annulus recovery. This is neocord implantation for anterior leaflets. During the rupture, you can do different exclusion of prolapses of P2, posterior wall. There's some different part of suturing. And also we general implant, so-called the ring, generally physio ring. But you should correctly put this ring because you need to calculate the length of the anterior leaflets, and you should have good coaptation with normal rings. Never try to put so small ring, otherwise you have a big problem with this reparation. So like I mentioned before, we always use physio ring in our practice. And some patient with normal anterior leaflet, we prefer to use so-called PTFA band, which starts with anterior lateral commissure finished. It takes maybe 10 minutes to put, and long-term results in our hand shows good results. What kind of approach to the heart sternotomy generally, but we can use minimally invasive approach for mitral valve and atrial fibrillation ablation. This is 4 intercostal space, 7 centimeter length of thoracotomy, peripheral cannulation, and you can open the pericardium. You can use cryo, radiofrequency, just perform Cox-Maze-4 procedure. This is how it looks in the operating room. This is incision. Looks like 6 centimeters in our hand. In this case, we use cryo. And we generally start to put so-called the clip in the left atrial appendage. And today, isolation of a left atrial appendage is class 1 indication for each surgical case in patient with atrial fibrillation. And if you look like after 3 years follow-up, this appendage in CT before, and after 3 years follow-up, disappeared absolutely. But you can see here the clip still okay in right side. What about technique for surgery? So different techniques exist. I already mentioned is a cryo, although bipolar radiofrequency is most applicable today. But I would like to show the McCartney procedure, which we did here in Moscow a couple years, 5 years ago already. After open the Waterstone wall, we go in left atrium, put in cryo around left pulmonary vein, close to mitral valve. First application, 2-3 minutes. Second application comes to the mitral valve, just isolate whole posterior wall. And third application goes through the coronary sinus, again to mitral annulus, just to be sure we have all line is continuous, quite enough to isolate all this posterior wall. 3 application, 3 minutes, it means 9 minutes totally. After that, we need to go on right side, always for persistency. Superior line goes from this incision to the vena cava superior, inferior goes to vena cava inferior. The third line goes to right lateral isthmus to prevent typical atrial fibrillation reoccurrences in follow-up. Totally 6 application, 20 minutes totally. I think this is very interesting technique, which I recommend for the AFib ablation procedure. What about robotic? A lot of people talking about this small incision. You can put in valve here, you can put ring, but I would like to take fan-friendly. Only maybe 3 and 4 surgeons use this technique. Is popular only in very, very advanced hands. Before I start to talk about our results, I would like to remind you this meta-analysis by Iranki, which is published in this year. This is meta-analysis include 31 publication, which include total 8,300 patients with atrial fibrillation and mitral valve disease. Hospital mortality was 1.7. What about survival rate? 1 year survival rate was 93%. 5 year survival rate, 87%. What about arrhythmia-free? 90% after 1 year combined surgery and 73% 5 years follow-up. Graphically, it looks like this. This is survival proportion after 5 years follow-up. One again, 83%. This arrhythmia-free survival rate close to 73%. Looks good. But most important part is pacemaker implantation. In this study, only 4% of pacemaker implantation. Remember, generally, after MACE 3, we have 10% of pacemaker, and after MACE 4, in this case, only 4%. In our hand is only 2%. Okay, about personal results. We try to compare combined RF, modified Cox-Maze, Damiano procedure, against RF-modified Cox-Maze-4 Benusi procedure for concomitant surgery atrial fibrillation in mitral valve surgery. Let me remind you about cryomaze on RF cryomaze by Damiano. The left side design of the line, right side design. For the Benusi, only one difference. They use a bipolar clamp only, and he performed this posterior line, goes through the mitral annulus and clip this clamp couple times, but you should be very careful for circumflexatory. You should be out of this clamping. But procedure is working. We have 266 patients in this case. We made replacement of mitral valve. We compared Damiano versus Benussi by cross-matching, 33 in one group and 32 patients in the second group. No difference according to the rhythm before surgery. Generally, patient had persistent atrial fibrillation. We replaced mitral valve in all cases because it was rheumatic disease, mechanically valve. Most of them biological, only maybe 10–50%. What about results? After discharge, 90% in sinus. After Benussi procedure, bipolar RFA. After cryo, 100%. But statistically, no significant. Again, after 4 years follow-up, 50 months. What about freedom for atrial fibrillation? 68 after bipolar radiofrequency ablation Benussi procedure and 73% after RF cryo Damiani procedure. So close to significantly, but okay, already no significantly different. This is a Kaplan-Meier curve freedom from the before PSM, 76% after Damiano case, it means cryo and RF in only 62 and 8% after Benussi case. After cross-matching, you see no big difference, but again, cryo looks much better. So in our case, we have 6% touch-up by catheter because we have atypical atrial flutter. But myself, I performed transeptal puncture, MAPE, this atypical flutter, close gap by using radiofrequency ablation technology, like shown here. In same hand, in open, in closed chest. So finally, I would like to show some innovation in ablation during the surgery. NIP8 presented this in XMIX meeting a couple of months ago. He tried to use bipolar clamp, but PF ablation, pulse field ablation. He showed if you have tissue 12 millimeter thickness, you can do for a couple of seconds this transmural lesion. This is experimental data. We will see in the future if we replace bipolar or cryoablation procedure. Finally, I would like to say, patient undergoing mitral valve replacement or plastic with persistent atrial fibrillation should have concomitant ablation of atrial fibrillation. It should be RF plus cryoMACE 4 or cryoMACE 4, generally. Thank you very much for your attention. I'm ready for the question.